Good afternoon, everybody. Today I want to start course lecture from urology. We will have 5 lectures, and the first our topic include specific and non-specific inflammatory disease. I want to start from the acute pyelonephritis. What is it, acute pyelonephritis? It's a non-specific infectious disease that involves the pelvis. If you remember where situated our pelvis, also calyces, we have 3, 4, 5 calyces, and parenchyma, particularly its intestinal tissue. About 20 to 40% of patients with renal disease suffers of the pyelonephritis. In my country, in your country, but sometimes the level of these patients increase because sometimes we have pathologicals, for example, urinary stone disease, congenital abnormalities, and the level of the pyelonephritis increase from the pathologicals. From the statistic factors, approximately 250,000 cases of acute pyelonephritis occur each year, resulting in more than 100,000 hospitalizations. We know that women are approximately 5 times more likely than men to be hospitalized with these conditions if we compare 11.7 versus to 2.4 hospitalizations per 10,000 cases, respectively. However, women have a lower mortality rate than men, 7.3 versus to 16.5 deaths per 1,000 cases, respectively. What are the etiological factors? We know that very often we have specific flora that called Escherichia coli. About 60 to 80% of acute pyelonephritis, the etiological agents, is this specific flora. Other etiological causes include aerobic gram-negative bacteria, also gram-positive, for example, Staphylococcus, Streptococcus, and others. This flora change from the different situations, and if we have, for example, completed infections such as acute cystitis, acute pyelonephritis, very often we find Escherichia coli. But if we have not a hospital flora, the level of this Escherichia coli decrease, and the level specific flora, for example, Proteus, Klebsiella, increase. And also specific flora, Staphylococcus, Streptococcus, after hematogenical spread. In this picture, we can see microbial organism causing specific types of urinary tract infections. For example, if we have, for example, acute uncomplicated pyelonephritis, very often we find Escherichia coli, Staphylococcus 0,1, Proteus only 4%, so we can see mixed flora only 5. But if we have complicated urinary tract infections or catheter-associated urinary tract infections, the Escherichia coli decrease, but the level Pseudomonas aeruginosa, Enterococci, Klebsiella increase. That's why we must understand that sometimes this flora change. What is the pathogenesis? Infectious usually ascends from the urethra and lower genitourinary tract. I said that the level of this pyelonephritis more in the women. Why? Because the short urethra in girls and women, and it's close proximately to the anus, allow periurethral pathogenical bacteria easy ascends to the bladder during sexual intercourse or sometimes after urethral manipulations, also maybe after some congenital abnormalities, for example, vesico-ureteral reflux and others. Once bladder infection is established, where the infections are sent via the ureters and involves the kidneys. It's influenced by the microbial virulence factors, the presence or absence of the vesico-ureteral reflux, the quality of ureteral peristaltic, and the susceptibility of the renal medulla to infections. There are four main spreads, but very often from the pathogenesis we have hematogenical spreads. What is the hematogenical spreads? Infections spread from the distant place. For example, if we have before the acute pyelonephritis pathological that called, for example, otitis, tonsillitis, bronchitis, pneumonia, osteomyelitis, mastitis, and others. Urinogenical spread. Infections goes at the ureter from the bladder because of the vesico-ureteral reflux. The pelvico-venous, pelvico-lymphatical, fornical, and tubercular reflux may be occurs. Ascendance infections from the ureter and the supraepithelium tissue pass direct into the intestinal tissue of the kidney. And very rarely we have lymphatogenetical spread. The infections by means of the lymphatical canals probability occur, but it's the promote factors that general. For example, avitaminosis, supercooling, infections, disease, gastric ulcer, local intravesical obstructions, neuromuscular dysplasia of ureter, benign prostata hyperplasia, and others. In this picture we can see if we have, for example, problem with the lower part, it's a urogenetical spread. If you have, for example, stricture in the neck of the bladder or stricture of ureter and problem with the uretero-vesical junctions, sometimes we have vesico-ureteral reflux. Very often these pathologicals we find in the young ladies between 20–14-year-old, and the ladies feeling pain in the lumbar regions and go to the toilet. It's specific factors. Also, Escherichia coli is specific flora that fixed in the urothelium. That's why you must go to the toilet very regular, because if the bacteria found in the blood and urethra, very often this bacteria pass through the ureter to the reflux to the kidney. Also, whipping from the back to front after a bowel movement may be force germs into the urethra. We'll go to the toilet because reflux. Also, after sexual life, very often after second, third days, we will have problem in the kidney because infections pass through the urethra to the bladder and through the bladder to the kidney after sexual lives. Now I want to stop from this moment. Fashions from the underwear from women change, and if we have underwear from women in the 18th and 19th century, and now the specific string that contact with the anus, anorectal zones, that infections pass through the anus to the urethra and from the ascendance part to the urinary bladder and kidney. Next, industry produce a lot of anti-gagayan, but sometimes contribute to the changing acid vagina, and after this anti-gagayan, the ladies feeling problem in the lower urinary tract, and infections pass to the urinary bladder and pass to the kidney from this acidity from the vagina change. We like sexual life. We know that in the Kama Sutra is a tract from the law. We have 64 positions, but now in the book we find 100 the best sexual positions, 365 from the everydays. It's a gymnastic, it's a acrobatics, it's a contact with the anorectal zones, it's a contact from the bacteria through the anorectal zone to the vagina, to the urethra, and pass to the urinary bladder, and ascendant pass to the kidney. And we will have specific acute pyelonephritis. Very important moment. Please understand this moment. What? How we divide, how we use classification of the pyelonephritis. We have primary and secondary pyelonephritis. Very important moment. If we have dysfunctions of the urinary outflow during, it's a primary pyelonephritis. There is no dysfunction. If you have secondary pyelonephritis, goes with the urostasis. Simple. If you have problem with the output of urea, for example, in this picture we can see a stone that's situated in the middle part of the ureter. Problem with the output of urea. Dilatations, ureter dilatation, the calico-pelvic systems, it's secondary pyelonephritis. But if the infections pass to the pelvis, colitis, parenchyma, through the gametogenic factors, it's primary, without dysfunction. What is the reason secondary pyelonephritis? Because urology symptomatics include more than 90%, it's a secondary pyelonephritis. Because primary pyelonephritis, if you have dysfunctions, treatment in the nephrology department. For example, in this picture, we can see, we use cystoscopy, we can see tumor mass that compress right orifice. Problem with the output, compress. In this picture, we can see ureterocelum and small stone that situated in the intramural part of the ureter. Problem with the output of urea. Scam, benign prostatic hyperplasia. Enlargement, benign prostatic hyperplasia. To lobe, compress the prostatic part of the urethra. Problem with the output of urea. Enlargement, urinary bladder, ureterohydronephrosis, problem with the output of urea. We have secondary pyelonephritis. For example, congenital pathologicals, stricture in the pyloureteral segments. On the excretory urogram we can see the stricture and filling defect may be stones situated in the pelvis. Problem with the output. Give me information how we studied if we have problem or not. We use methods and vesicle methods that called chromocystoscopy. But first of all, we use cystoscopy in the instrumental examinations in a part of the urinary bladder. After that, we introduce 0.4% indigo carmine, and after 35 minutes, we will see output of urea color in blue. But first of all, I want to stop what is it cystoscopy.
Your doctor has recommended that you undergo a cystoscopy. But what does that actually mean? The lower urinary tract allows your body to store and release urine. It's made up of two parts, the bladder and the urethra. Your bladder is a hollow organ that expands as it fills with urine. Because it is made of muscular tissue, it can also contract and force urine to pass out of the body through the urethra. Your urethra carries urine from the bladder all the way through the opening in the penis. Your doctor feels that it is necessary to examine the interior of the urethra and bladder to try to determine the cause of the problem that you may be having. Symptoms that may call for a routine cystoscopy include persistent infection of the urinary tract, bladder stones,
It's what
bleeding while
situations, what
urinating,
indication to cystoscopy?
irritation due to polyps, or changes to the bladder caused by cancer. Cystoscopy is a simple procedure during which your doctor will insert a well-lubricated instrument called a cystoscope through your urethra and into your bladder. The cystoscope allows your doctor to visually inspect the interior of your bladder. It also allows your doctor to remove small pieces of tissue for later examination, and even to crush small bladder stones should any be present. Any tissue that your doctor removes from your bladder will be sent immediately to a laboratory for analysis. Your doctor will ask the laboratory to check for any sign of cancer or other abnormality. Your doctor will then lift your penis upward. A well-lubricated cystoscope is gently inserted into the urethra, the opening at the head of the penis, and slowly guided inward. When the cystoscope reaches the back of the penis, your doctor will pull the penis downward in order to create a straight path into the bladder. Once the cystoscope is inside the bladder, your doctor will inject a small amount of water through the cystoscope and into the bladder. The water serves to expand the bladder, helping your doctor to better examine the interior. It also helps by washing away any blood or remaining urine. You may feel a sense of fullness as though you need to urinate. You'll be encouraged to relax and not to try to retain the water in your bladder. As the team completes the inspection, they'll be looking for suspicious tissues. If they find bladder stones, your doctor may try to crush these so that they can pass out of the bladder during normal urination. If the team finds a suspicious growth, they will use a special grasping tool to take a sample of the tissue in order to send it to a laboratory for analysis. When the inspection is complete, your doctor will remove the cystoscope and you'll be asked to empty your bladder. Your doctor will probably ask you to wear a temporary Foley catheter. A Foley catheter is a narrow tube inserted through the urethra and into your bladder. The catheter is connected to a bag that is attached to your leg by a strap. While the Foley catheter is in place, urine will pass from your bladder into the bag. You will not need to urinate into a toilet. The nurse will show you how to change the bag when it's full. An appointment will be made for you to return to the doctor's office in a couple of days to have the catheter removed. As soon as the anesthesia wears off and you feel comfortable, you'll be allowed to leave.
Okay, you understand these manipulations, but I want to say that contraindication to cystoscopy if we have acute inflammatory disease of the lower urinary tract, for example, acute cystitis, acute urethritis, acute urethritis, prostatitis, and others. And there are three conditions to cystoscopy if the path cystoscope through the urethra, volume of urinary bladder more than 75 milliliters, and visual control. Because if you have profuse bleeding or stricture of urethra on the very small volume of urinary bladder, we never use these manipulations. That's why we must these conditions. First of all, we use cystoscopy. After that, from the study of the function of the kidney, because I don't know if we have primary or secondary pyelonephritis. I said if we have problem with the output of urea, we will have secondary pyelonephritis, and tactic of the treatment is different. Endovesical examinations, chromocystoscopy. Cystoscopy, visual control. After that, the nurse introduce intravenous 0.4%, 35 milliliters indigo carmine, and after 3-5 minutes we will see out urea color in blue. In this picture we can see. Now I take the laser tip. You can see output urea color in blue. Second method that called excretory urography. We give for us anatomy functionality. We introduce contrast material, for example, trion brass, urographene, varographene, 20-40 milliliter, 76% this iodine drugs before we use sensitivity test, and after 5-7 minutes we take picture. It's an X-ray examination, so we can see. And we can see anatomy function ability. Pelvis, calyces, piloureteral junctions, urinary blood. It's called excretory urography. And radioisotopic renography. Iodine-specific drugs, and we studied if we have problem with the output or not. Also, sometimes we use expensive methods that called CT with the contrast materials. It also gives for us very good informations. We continue classifications. First of all, it's a primary, secondary. Also, we divide unilateral or bilateral. I think it understands. Acute pyelonephritis we divide to the serious and purulent, chronic, relapsing cause. By the mode of bacterial pathways there are different: hematogenics, ascendants, urinogenics. If you have, for example, urolithiasis, infections urinary stones, we call it calculous pyelonephritis. If you have tuberculosis of the kidney, also you have pyelonephritis, and other renal disease. By the course age stage of the organism there are different: the pyelonephritis of newborn, the pyelonephritis of the aged patients, the pyelonephritis of the pregnant women, pyelonephritis diabetes mellitus patients, and others. What the risk factors for complicated acute pyelonephritis? Age. Infants and elderly more than 60 years of age. I think it understands. If we have anatomic functional abnormality, for example, it's a polycystic kidney disease, Herschel kidney, double ureter, ureterothelin, double kidney, vesicoureteral reflux, and other. Immunosuppressed state, diabetes mellitus, sickle cell disease, transplantations, malignancy, chemoradiations, have infections, corticosteroid use, male sex. Also, if you have obstructions, it's very big risk factors, and very often we find these pathologicals in the urology department. If we have calculi, bladder neck obstructions, posterior ureteral valve, benign prostatic hyperplasia, cancer of the prostate, neurogenital bladder, pregnancy, and foreign body. What the clinical findings? What the main symptoms? The spectrum of acute pyelonephritis is wide, ranging from the mild illness to sepsis syndrome. The usual symptoms of acute pyelonephritis include abrupt onset of shaking chills, moderate to higher fever, constant ache in the line, unilateral or bilateral. Symptoms specific from the lower urinary tract, specific from the cystitis, frequency, nocturia, urgency, and dysuria. Significant malaise and prostration are the rule, nausea, vomiting, and even diarrhea and coma. The young children more often complain of a poorly localized abdominal discomfort and seldom localizes the discomfort specifically to the flank. Sign. The patient generally appears quite ill. Intermittent chills are associated with a fever ranging from the 38 to 40 degrees Celsius and tachycardia 90 to 140 by minutes or faster. First percussions over the costovertebral angles that we call symptom by Pasternatsky very often if you use percussion in the lumbar regions, is positive. The kidney often can't be palpated because of tenderness and overlying muscle spasm. Abdominal distension may be marked, and rebound tenderness may suggest as intraperineal lesions. Auscultations usually reveals a quiet intestine. Laboratory. No, first of all, we use a urinalysis for to give for us. Usually cloudy fluid with heavy pyuria, bacteriuria. I want to say that in the first 2-3 days we find only bacteriuria, but after that leukocyturia, mild proteinuria, and often microscopic or gross hematuria. Urinary culture are positive in 90% of patients with acute pyelonephritis, and culture should be obtained before antibiotic therapy is initiated. It's very important because now sensitivity to antibiotics change every 10 years. That's why if I start my practical work 32 years ago, I use only antibiotics, aminoglycoside, and cephalosporin first generations, but now we use third, fourth generation cephalosporin, ftorhinolone, and others. Every 10-20 year change more than 20-40% of all the. That's why urinary culture we take in all situations before antibiotics. Non-invasive methods that calls ultrasonography. Ultrasonography shows flattering and dilatation of the calyces and pelvis, dysfunctions of urinary passage, because if we have secondary pyelonephritis problem with the output, we must remember that our pelvis 2 to 2 centimeters small calyces, the size of our inner part of the ureter 4 millimeters, but if the doctor give for us, for example, 9-12 millimeters dilatations of the pelvis 5 to 6 centimeters, we suspect that we have problem with the output. Also, what's the parenchyma? If you remember from anatomy and top anatomy that the parenchyma in the older patients, for example, 16-18 millimeters, but we have very thin in parenchyma bar or the edema of the parenchyma. It also gives us information that we will have problem. Also shows the size of the concrements and the kidney and others. In this picture we can see dilated pelvicocalyces systems in female patients with the acute onset of flaque pain, radiation on the genitalium, and also edema of the parenchyma. Next step is X-ray examinations. In all cases, we start from the plain field, or maybe QB. In Ukrainian country we call it objective urography, American QB, and the plain film gives us information, shows some degree of obliteration of the renal outline owing to edema of the kidney and perinephrical fat. The outline of the iliopsoas muscle is absent. We know that, for example, in this picture very good we can see it's a muscle's psoas. But if we have edema in this part, we cannot see this shadow of these muscles. Also, small scoliosis may be. In this picture, we can see coral, big stone in the right kidney and stone in the lower calyces. In these situations, we can see in the plain film stones are situated in the left kidney, stones are situated in the right kidney. Also, maybe we can see the size of the kidney, enlargement sometimes if you have edema or obliterations in the lower part. Also, sometimes deformations, the poles of the kidney. But very often the pathologicals we find if we have purulent form of the pyelonephritis. Next step is excretory urography. I said that excretory urography gives us anatomy function ability. We can see anatomic of the calico-pelvis systems and also function of the kidney. We introduce contrast materials, I said 20, 40, 60 milliliter, 76%, and after 6-7 minutes we take fast picture, and after that continue on the dynamic. For example, what pathologicals we can see? In this picture, filling defect in the pelvis, suspect the stone. Also, stricture the piloureteral segments, filling defect. It's indication to operative treatment, for my opinion, because we have stricture, remove the kidney, plastic operations. In this excretory urography, we can see problem in the middle part of the right ureter. If we compare left part, thinning ureter, normal size, pelvis, upper, middle, lower calyces, but in these situations we can see ureteral hydronephrosis, dilatation of the ureter and calico-pelvis systems. Problem in the middle part. And in this picture we can see problem structure or obstructions in the uretero-vesical junctions. It's also indication to plastic operations. We find cause of this problem. Instrumental examinations, I said, from the cystoscopy. What we can see? For example, edema of the orifice, tumor mass, benign prostatic hyperplasia, and complication small stone. And we use chromocystoscopy, dilatations, ureterocella in this picture, and also problem with output of urine. That's why give for us informations what the cause obstruction pyelonephritis. Differentiated diagnosis. We use differentiated diagnosis with cholecystitis, appendicitis, lower lobe pneumonia, perforatus viscus, and the prodrome and herpes zoster. If you use additional methods and compare these additional methods, give for us good information. What is this? For example, if we use we have cholecystitis and acute right pyelonephritis. We use ultrasound, maybe find stone in the cholesterol, maybe we find stone in the kidney, what is the level bilirubin, what's the level diastase, and others. We compare these methods. If you have, for example, pneumonia, maybe lower part, X-ray examinations, X-ray film, chest X-ray film, give for us information that we have pneumonia or CT on the lung. Also give, and these additional methods give for us good information. In this picture we can see differentiated diagnosis from the different urology symptomatic. For example, polycavernous tuberculosis. Also we have pyelonephritis, sclerosis of the kidney, hydronephrosis, dilatation, pelvis and parenchyma, tumor in the upper poles. Also clinical, pain in the lumbar regions, pyuria, hematuria, strictures the piloureteral segments, dilatations, pyelactasia, and the tumor. What treatment do we use? Specific measure, general measure, failure of response, and follow-up care. What specific measure? When the infection is severe or complicated factors are present, hospitalizations may be required. Urinary and blood specimens must be obtained immediately for culture. Recognized pathogens must be tested for the antimicrobial sensitivity. Until the results of the test are known, antimicrobial drugs should be given imperially. We prescribe antibiotics the wide specters, for example, cephalosporin, second, third generations, and ftorhinolone, second or third generations. What is the indication for hospitalization in patients with acute pyelonephritis? Absolute indications: persistent vomiting, progression of uncomplicated urinary tract infections, suspect sepsis, uncertain diagnosis, urinary tract obstructions. Relative indications: age more than 60 years, anatomic urinary tract abnormality, immunocompromised diabetes mellitus, cancer, sickle cell disease, frailty, poor social support. First of all, we start the complete bed rest is advised until symptoms subside. Medication should be given for pain, fever, and nausea. It's important to give fluids intravenously and orally to ensure adequate hydratations and maintenance to adequate urinary output. First of all, once more remember that we start from the excretory or endovesical examination homocystoscopy. We start if we have problem with the output of urine or not. Because if we have problem with the output of urine and we prescribe antibiotics, in the future we will have iatrogenic bacteremic shock. That's why if we have problem with the output of urea, we use catheterization of the kidney. We take catheterization cystoscope. We find where situated orifice. For example, we have problem with the output of urea from the right kidney. I find the right orifice and pass catheter through the ureter to the kidney. Or if we have problem with the pass catheter, we use percutaneous nephrostomy with the visual control by the ultrasound. We pass needle through the skin to the kidney. And if we have drainage, after that we prescribe antibiotics the wide spectrum. For example, it's cephalosporin, ceftum, cefoxime, Kevzol, 1-2 grams twice a day intravenous only. Next groups, it's a ftorhinolone, levoflox, levomac, levofloxacin, norfloxacin. If we have second generations, 100 twice a day intravenous. If we have third generations, we prescribe 100 milliliters 1 times a day. In this picture, we can see different dosage from the antibiotics and first of all, we prescribe only intravenous, but after 5-7 days, if we have good dynamic, maybe prescribes per oral dosage. It's cefotaxime, cloforal, it's ceftriaxone, rosifin, cephalexin, Keflex, ciprofloxacin, cipronorfloxacin. We can see different dosage, and I think you know these drugs that it's very often we prescribe if we have acute pyelonephritis. Next group that I want to stop, it's acute purulent pyelonephritis. We divide to the apostematosis, renal carbuncle, abscess of the kidney. What is it, apostematosis pyelonephritis? It's a suppuration of the parenchyma of the kidney with formations of the small multiple purulent focus. In this picture we can see apostema, we call it. The process occurs unilateral and bilateral. The purulent focuses are direct under the fibrous capsula, 1-3 mm in diameter, and margin sometimes. Renal abscess, renal cortical abscess develop primarily as a result of the hematogenical spread of the Staphylococcus aureus infections and the distant side, most often the skin furunculosis, phelon, mastitis, osteomyelitis, and others. At times, foci of primary infections caused mainly by gram-negative bacteria coliform organism, colitis in the renal medulla to the form abscess. In this picture, we can see abscess in the upper poles. In the past, most renal abscesses were caused by the staphylococcus. Recently, coliform bacteria have become the predominant pathogens in the renal abscess. Sometimes this abscess pass to the paranephritic fat and we will have complications, paranephritis. And the third groups of the purulent form is the renal carbuncle. In this suppurated necrotic damage with the formation of the bodurit infiltrated in the cortex of the kidney. Renal cortical carbuncles develop primarily as a result of the hematogenical spread of the infection from the distant side, most often from the respiratory tract, suppurative disease of the kidney, skin, tuberculosis, phelon, mastitis. Mechanism of carbuncle formation is the septic embolism of the renal arteria that causes the septic infection of the kidney and the development of the carbuncle. In this picture we can see carbuncle, big carbuncle is situated small apostema and a big carbuncle is situated in the middle part of the kidney. What the clinic? Symptoms specific from the acute pyelonephritis. Renal abscess is typified by the abrupt onset of the chills, fever, and localized costovertebral pain. In the early stage, when the abscess does not communicate with the collective systems, symptoms of vesical irritability are absent, and urinalysis sometimes is normal. That's why it's problem from the diagnosis, because the patients have high temperature, chills, and without problem in the urinalysis. What's the sign? In acute cases, localized signs are flank tenderness, possibility palpable mass, and erythema and edema of the skin of the overlying line. At times, however, abscesses associated with both acute and chronic infections present in the febrile illness with a few localized signs. Laboratory findings. The hemogram usually shows marked leukocytosis with a shift of the left. With the cortical abscess that do not communicate with the collective systems, urinalysis, I said, shows no pyuria or bacteriuria, and urinary culture is negative. Medullary abscess generally associated with the heavy pyuria, bacteriuria, and positive urinary culture. Blood culture may be positive, but we must take this blood culture if we have higher temperature and chills. Depending upon the extent to renal entrainment of the associated renal abnormalities, the serum creatinine and urine nitrogen values may be normal or elevated. Very important moment, if we have obstruction from the both sides, sometimes we have increased level of creatinine and urea. It's specific from the study if we have renal insufficiency or not. I think you remember that normal our urea 8.3 millimole for liters, but creatinine 0.1 millimole for liters or 100 micromole for milliliters. X-ray signs give us informations. Maybe stone we find the situated, for example, stone is situated in the left kidney, coral stone from the both sides, abscess, musculus psoas, enlargement the pelvis, deformations the poles, upper, lower, middle were situated abscess or carbuncle, and small scoliosis. In this picture we can see small scoliosis. It's specific from the side. On the excretory urography, when the cortical abscesses are small, we haven't information from the deformations, calyces or pelvis. But if we have enlargement, abscess or carbuncle, maybe deformations, the calyces in this picture we can see, poor function, maybe pyonephritic change, hydronephrosis, maybe we can see urolithiasis. It's specific from the problem with the kidney. This picture we can see pyelonephritic change, hydronephrosis, and urolithiasis. Stone, for example, in the pneumoureteropyelography is situated in the middle part of the ureter, pneumopyelography, and also dilatations, calicopelvis systems. But the good informations we find if we use ultrasound examinations. Intrarenal abscess appear as well, marginal to round or oval masses with a kidney. We can see the mass may be echo-free or slightly echogenic due to presence of necrotic debris. Dilatation the calicopelvis system and formation the small abscess. Also, we can see in this picture formation the small abscess. Sometimes we use differentiated between carbuncle and tumor mass. That's why we use modifications ultrasound examinations that called Dopplerography of the kidney. We studied vascularizations. You remember that if we have tumor mass, we have additional vascularizations, but if we have carbuncle or abscess of the kidney, we cannot have mass additional vascularizations. We have hypoechogenic that's situated in the cortical part of the kidney. Very good informations, and from the protocol European and American Associated of Urology, in all cases we use CT with the contrast if we have good function of the kidney, if the level urea and creatinine and normal, we use CT with the contrast. We can see, for example, in this picture, abscess of the upper poles. This picture also anachogenic mass situated in the cortical part. Also a big abscess. It's a good information, and also we have information from the contralateral kidney, from the function of the kidney, because sometimes if you remove kidney, if you have very big abscess or carbuncle, we must know the function of the contralateral kidney. Treatment. In this picture of Visalia, if you have acute purulent pyelonephritis, it's indication to operative treatment. What treatment? Its urgent surgical measures are required. The subcostal lumpectomy is performed. Because if you have pus in the kidney, we never use laparotomy, because sometimes we have pus that pass to the abdominal cavity. The kidney is new to the decapsulated. The purulent focus are incised. The retroperitoneum space should be drained and free output of the urine provided by means of the nephrostomy from the good drainage. The surgical drainage should be present until the urinary output becomes free. Inflammations, decapses are renal functions normalized. The postoperative period requires the antibacterial and disintoxicant treatment that is similar to the chronic pyelonephritis. If we have a renal carbuncle, lumpectomy is performed, then decapsulations. In this picture, we can see decapsulations. We remove the capsula adiposa, and cone-shaped excisions of the carbuncle are done. Incisions, curettage, and drainage of the kidney or enucleated of the carbuncle with its incisions may be performed too. Nephrectomy and partial nephrectomy are required less often today than its past. Because we have good antibiotics, we use good technique of operations. Sometimes without operations, we use non-invasive methods. We use percutaneous nephrostomy or decapsulations, some small decapsulations, and also prescribes a very good antibiotic from the wide spectrum. Now we can see some moment of the we can see open nephrectomy. We remove retroperitoneum. In these situations, we use laparotomy. It's really free surround tissue, and the blue color, it's a vein, renal vein. It's a white color, it's a renal arteria. Free surround tissue. Arteria renalis. Next step, we clamp arteria renalis. Suture and ligations. And ligations of vena renalis. It's vena renalis. Clamp. Future implications, venal analysis. I think you understand this moment, and after that we remove the kidney. Good visual control, and profuse bleeding. We remove the kidney. Next group of the pyelonephritis is very important group. It's the gestation pyelonephritis. The inflammatory process develops while pregnancy, delivery, and puerperal period. What we have, what clinic? Most frequently is observed in the pregnant, more rarely in puerperal period. In developing while fast pregnancy, second trimester, there are women 18 to 25-year-old. What are the etiological factors? Urine culture find out Escherichia coli, Staphylococcus elegans, Klebsiella in pregnant women. Associated of the Proteus and blue pus bacille is observed in puerperal women. The primary source of the infections may be any puerperal inflammatory place if we have problems with furunculosis, dental caries, inflammatory disease of the genital organs, and others. Pathogenesis. It's a very important moment. The pathogenesis site is bacteriuria. It's observed in 80 to 90 only percent of all patients, and in the 20 to 40 of women with asymptomatic bacteriuria develop pyelonephritis during the pregnancy. Treatment of the bacteriuria lowers this risk. Urodynamic dysfunctions favor the pyelonephritis development. Pathogenesis may be explained with the mechanical, neurohormonal, and endocrine factor. We know that the enlarged uterus compresses the pelvic portion of the ureter, causing to the ureteropyeloctomy with the pregnancy women. We call this mechanism mechanical factor. If the enlargement uterus, deviations very often in the right side and compress the lower part of the ureter. Problem with the output of urea, and we have specific mechanism. Problem with the output is dilatation of the calicopelvis systems. The moderate hypotonia and hypokinesis of the calicopelvis of the both kidney and ureter are observed on the 8th week. Change of the upper portion of urinary tract may be explained by the weakening of the asymptomatic nervous system tonus. Dysfunctions of the urinary output because of the urinary pathway atonia is the condition for the pathogenic activations. Vesiculourethral and pelviculourethral reflux favor spreading of the infection into the intestinal tissue of the renal parenchyma. What are the clinical findings if we have pyelonephritis of the pregnancy? How often peculiarly according of the different times of the pregnancy. They also depend on the range of the urinary output damage. A sharp pain in the loin that irradiated to the lower portion of the abdomen. Genitals are the first trimester. and second and third trimester are characterized with a moderate pain because of the dilatation of the upper urinary tract and intrarenal pressure decreasing. An acute puerperal and pyelonephritis development more frequency in the pregnant and postpuerperal women. Symptoms. The usual symptoms of acute pregnancy pyelonephritis include abrupt onset of shaking, chills, moderate to higher fever, a constant ache in the line, unilateral or bilateral. Symptoms specific from the lower urinary tract infections, frequency, urinations, urgency, dysuria. Significant malaise and prostration are the rule, nausea, vomiting, and others. What is the diagnostic program? First of all, we never use X-ray examinations. We never use CT with a contrast because it's a problem from the fetus. Laboratory findings and vesical examination from the study if we have problem with the output or not. It's chromocystoscopy and ultrasound examination. It is the main important moment. Once more repeat, chromocystoscopy, introduce 0.4% indigo carmine. After 3-5 minutes, we can see output urea, color in blue. And if we have problem with the output of urea, we cannot see after 10-15 minutes. That's why we'll have problem. Next, ultrasound examinations. What we can see? We can see dilatation the calicopelvis systems. We suspect maybe problem with the output, enlargement of the kidney, edema of the parenchyma, dilatations ureter, because if we have mechanical factors, it's compressed in the lower part of the ureter. That's why it dilatations the upper portion. 10, 12, 15 millimeters. That's why we suspect the problem from the output of urea. What treatment? First of all, it's position therapy. If you have problem from the right side, but I said that in the second trimester, dilatation, enlargement uterus, deviation in the right side. That's why, what is it specific positions, position therapy? Lie on the left side. Antibiotics should be harmful to fetus. The nature and semi-synthetic penicillin are recommended at the first trimester. Why the choose of antibiotic is at the second and third trimester? Because placenta has its barrier functions then ampicillin, gentamicin, cefazolin, ceftriaxone, and others. We never use ftorhinolone, we never use sulfanilamide because it's a problem from the fetus. The puerperal women may be transferred drugs to child with the milk. The acute puerperal and pyelonephritis in pregnant women requires the obligate surgical measure. If we have problem with the output of urea, but before we use chromocystoscopy, and I know if we have problem with the output or not. Also, I use ultrasound examinations, dilatations calicopelvis system, dilatation of ureter, higher temperature, edema of the parenchyma, indication to drainage of the kidney. That's why we use cystoscopy, visual control, we take catheterization cystoscope, we find where situated orifice and pass through this orifice catheteric to the 28-30 centimeters. If we have problem with the catheterizations, it's indication to percutaneous nephrostomy. Visual control from the ultrasound examinations and pass needle through the needle where pass specific instrument from the dilatations, this part, and pass drainage to the kidney. It's called percutaneous nephrostoma. After that, we prescribe wide spectrum of antibiotics: semipenicillin, ampicillin, ampiox, cephalosporin, cefazolin, ceftriaxone, Kevzol, 1–2 grams twice a day intravenous. Disintoxicative measure and specific from say. Thank you for attention. Okay, continue. Now I want to say about the tuberculosis. It's a specific infectious disease. It's also very hardly pathological because sometimes without lung forms we have tuberculosis of the urinary tract. Tubercular bacilli may be invade one or more of the organs of the genitourinary tract and cause a chronic granulomatosis infection that shows the same characteristic as tuberculosis in the other organs. Urinary tuberculosis is the disease of the young adults. 60% of patients are between age of 20 to 40 years, and it's a little more common in males than in females. What are the etiological factors? The infection organs is a Mycobacterium tuberculosis, which raises the genitourinary organs by the hematogenical route from the lung. The primary site is often non-symptomatic or apparent. The kidney and possibly the prostate are the primary sites of tuberculosis infections in the genitourinary tract. All other genitourinary organs become involved either by ascent, prostate to bladder, or descent, kidney to bladder, prostate to epididymis. The testes may become involved by direct extractions from the epididymal infections. Pathogenesis. When a shower of tubercular bacilli hits the renal cortex, the organism may be destroyed by normal tissue resistance. Evidence of this is commonly seen in autopsy of persons who have died of the tuberculosis. Only scars are found in the kidneys. However, if enough bacteria of sufficient virulence becomes lodged in the kidney and are not overcome, a clinical infection is established. Tuberculosis of the kidney progresses slowly. It may take 15–20 years to destroy a kidney in a patient having a good resistance to the infections. The infections then proceed to the pelvis mucosa and the ureter, particularly its upper and vesical ends. This may be led to stricture and to back pressure that call to the hydronephrosis. Vesical irritability develops an early clinical manifestations on the disease, and the bladder is bathed by the infected material. Tubercles form later, usually in the region of the involved ureteral orifice, and finally cause and ulcerate. These ulcers may be bleed. With severe involvement, the bladder becomes fibrous and contracted. This leads to the MACD frequent. It's very often we call it microcyst, ureteral reflux or stenosis, and therefore hydronephrosis may be developed. If contralateral renal involvement occurs later, it's probability to separate hematogenical infections. What are the clinical findings? Tuberculosis of the genitourinary tract should be considered in the presence of any of the following situations: chronic cystitis that refuses to respond to adequate therapy, the finding of pus without bacteria in the methylene blue state or culture of the urinary sediments, gross or microscopic hematuria, a non-tender enlarged epididymis with a bedded or a thicket was, a chronic drained scrotal sinus, durations or nodulations of the prostate, and the sinking of the both seminal vesicles. A history of present and past tuberculosis of its body shows that the physician suspects tuberculosis in the genital urinary tract or symptoms are present. The diagnosis rests upon the demonstrations of the tubercle bacilli in the urinary biculture. The extent of the infections is determined by the palpable findings in the epididymis, vasa deferens, prostate, and seminal vesicles. We use objective examinations, its form that we palpable. The renal and ureteral lesions are revealed by the excretory urograms, involvement of the bladder and seen through the cystoscope. We can see specific signs that characteristic in the cystoscopy. The degree of renal damage as measured by the loss of functions, the presence of tubercle bacilli is one or both kidney. In this picture, we can see specific destroyed, the specific from the tuberculosis, and we divide to the fourth form from the classifications. First stage, non-destructive infiltrated tuberculosis of the kidney. Second stage, initial destructions, papillitis or small by the diameter about 1 centimeter single cavity. Third stage, marked destructions, caverns or polycavernosical tuberculosis, one of the kidney segments. And fourth form, total or subtotal destructions, polycavernous tuberculosis of two segments, tubercular pyonephrosis, calcifications of the kidney. They distinguish three forms of tuberculosis: tubercular infiltrative and ulcer and scar. What's the main symptoms? There is no classic clinical picture of renal tuberculosis. Most symptoms of this disease, even in the most advanced stage, are vesical and original cystitis. Its specific symptoms vary often from the lower urinary tract. It's a frequent urinations, difficult burning in the urinations, vague general malaise, fatigability, low grade by persistent fever, and night sweats are some of the non-specific complaints. Even vesical irritability may be absent, in which case only proper collections and examinations of the urine will find the clue. Active tuberculosis, elsewhere in the body, is found in less than half of patients with a genital urinary tuberculosis. What specific symptom from the kidney and ureter? Because of the slow progression of the disease, the affected kidneys is usually completely asymptomatic. On occasion, however, there may be a dull ache in the flank. The passage of blood clot, secondary calculi, or a mass of the debris may be cause renal and ureteral colic. Rarely, the presented symptoms may be a patient's mass in the abdomen. Symptoms specific from the lower urinary tract. The early symptoms of renal tuberculosis may be as from the secondary vesical involvement. These include burning, frequency, and nocturia. Hematuria is occasionally found and is of either renal or visceral origins. At times, particularly in the late stage of the disease, the vesical irritability may become extreme. The ulcerations occur, suprapubic pain may be noted when the bladder becomes full. Genital tract tuberculosis of the prostate and seminal vesicle usually cause no symptoms. The first clue to the presence of tuberculous infections of these organs is the onset of the tuberculous epididymitis. Tuberculosis of the epididymitis usually presents as a painless or only mildly painful swelling. An abscess may be drained spontaneously through the scrotal wall. That's why it's a visual. We can see the specific fistula and may be painful in the part of the epididymis. In rare cases, the onset is quite acute and may be simulate an acute non-specific epididymitis. Evidence of the exogenital tuberculosis may be found in lung, bone, lymph nodes, tonsillitis, intestines, and others. There is usually no enlargement of the tenderness of the involved kidney. Extrarenal genital, sinking, non-tender, or only slight tender epididymitis may be discovered. The vast difference offers is sinking and braided. A chronic draining sinus through the scrotal sin is almost pathological of the tuberculosis epididymitis. Laboratory findings. It's specific. We find specific flora presents pyuria without organism. We are often called the asymptomatic bacteriuria. We can see asymptomatic leukocyturia. About 15 to 20% of patients with the tuberculosis have secondary pyogenic infections that clue sterile pyuria is there observed. If clinical response to adequate treatment fails and pyuria persists, tuberculosis must be ruled out by the bacteriological and rentgenological means. Culture for tuberculous bacilli from the first morning urine are positive in a very high percentage of the cases of tuberculosis infections. If positive, sensitivity tests should be dated. The blood count may be normal or may show anemia in advanced disease. The sedimentation rate is usually accelerated. Tubercular bacilli may often be demonstrated in the secretions from the infected prostate. If tuberculosis is suspected, perform the tuberculosis test. A positive test, particularly in an adult, is hardly diagnosed, but a negative test in an otherwise healthy patient speaks against a diagnosis of tuberculosis. X-ray signs. A chest film that shows evidence of tuberculosis should cause to the physician to suspect tuberculosis of the urogenital tract in the presence of urinary signs and symptoms. What we can see on the plain film or QB, we can see show enlargement of one of obliterations in the kidney. Also, psoas shadows due to perinephritic abscess. Punctate calcification in the renal parenchyma may be due to the tuberculosis. Renal stones are found in 10% of all cases. Calcification of the ureter may be noted, but this is rare. Small prostatic stones, the size of great cysts in the region of the pubic symphysis, are ordinarily not due to tuberculosis, but large calcified bodies may be used. Also, what we can see if we use excretory urography. Once more repeat, we introduce contrast material intravenous and we studied anatomofunction ability. On the excretory urography, its specific typical change include moth-eaten appearance of the involved ulcer calyces, obliterations one of the more calyces, dilatations of the calyces due to ureteral stenosis or fibrosis. Very often we can see in this picture, we can see now I take the laser and we can see stricture and dilatation of the ureter. In this picture we can see stricture and dilatation. The, okay, that's why specific symptom from the tuberculosis. Abscess cavities that connect with the calyces that called caverna. Now we can see it's abscess cavity. Single or multiply ureteral stricture with the secondary dilatations. Abscess of the function of the kidney due to complete ureteral occlusions and renal destructions. In this picture we can see all dilatation and stricture of the urethra, also calcification in the prostate. On the excrete retrograde cystography, we can see specific symptoms. You can see small volume of the urinary bladder and vesico-ureter reflux. You can see vesico-ureter reflux. Also, excretory urography, dilatation and stricture of the lower part of the ureter. In these situations, it's indication to plastic operations that called operations by Boeree. After some minutes, I stop from this moment. We use incision the part of the urinary bladder and use new anastomosis between urinary bladder and normal diameter of the ureter. Also, from the diagnostic tuberculosis, we use additional methods such as that called cystoscopy. What we can see if we use cystoscopy? Dilatation the orifice, deformation the orifice, gray hump with the hyperemia. If we introduce solutions before examinations, we diagnose that the volume urinary blood is small, that called microcyst. Also, hyperemia near the orifice, ulcer, pass through the orifice, its specific symptom from the tuberculosis of the genitourinary tract. Differentiated diagnosis we use from the ulcer, from the tumor. In this picture we can see stone, because in all cases we have problem with the urinations. We have frequent urinations, we have difficult urinations, we have hematuria, pyuria and others. But if we have sterile pyuria, we cannot find specific flora, but we have pyuria. It's called sterile pyuria. It's specific. If we haven't effect after conservative treatment, it's also specific from the tuberculosis. Differentiated diagnosis. If we have stricture and filling defect, maybe stone, maybe papilla cancer in this picture, ureteral hydronephrosis, and specific symptom from the tuberculosis, dilatation and stricture of the ureter, caverna, calcification of parenchyma, tuberculosis, papillitis. That's why we use additional methods from the diagnosis. X-ray diagnosis, endovesical, and laboratory. In this picture also we can see different pathological in the kidney, but the clinic is the same. What treatment? Must be treatment as a general disease. Even when it can't be demonstrated on the urogenital tract, one must assume activity elsewhere. This means that basically the treatment is medical. Surgical excisions of uninfected organs, when indicated, it's merely and just the oral therapy. If we haven't effect from the conservative treatment, if we have some complications such as tuberculosis, pyonephrosis, stricture, prolonged stricture, yes, in these situations we use operative treatment. What conservative treatment? We use specific combinations of drugs, for example, cycloserine, aminosalicylate, and ionized. Cycloserine, ethambutol, and isoniazid. Rifampicin, ethambutol, and isoniazid. This drug we prescribe from the prolonged period, 3, 5, 6 months, sometimes before the 1 year. We prescribe these drugs. While most authorities advise appropriate medications for 2 years. They recommend 600 milligrams of rifampicin, 300 milligrams isoniazid, and 1 gram of pyrimidine, and 1 gram of vitamin C. Sometimes we change these combinations 3 months. After 3 months, we prescribe next combinations group from the good effects. Also, from the prognosis, the prognosis varies with the extent of the disease and the organs involved. By the overall control rate is 89–88% at 5 years. The urine must be studied bacteriology every 6 months during treatment and then every year for 10 years. Relapse will be indicated the need for the reinstructions of treatment. Nephrectomy is rarely necessary. In the hidden process, urethral stenosis or vesical contracture may be developed. Appropriate surgical interventions may be necessary. Once more repeat that if we have problem, decompensations problem, if we have pyonephrosis, polycavernous, and the good functions contralateral kidney, yes, we use modification operations, and sometimes we remove kidney, we use nephrectomy. But if we have very small volume of urinary bladder, sometimes we use plastic operations that formed new urinary bladder. Sometimes, if we have stricture the lower part of the ureter and good function of the kidney, we use operations that called operations by Boary. It's a plastic operations. Let's say. The prognosis from the tuberculosis is good if we start our therapy very early on the first stage, first, second, third stage, and if we haven't complication of these pathologicals. Okay, thank you very much for the attentions. I wish you good health and good future profession.